Welcome back to the session. Our next speaker is Dr. Bennett Greenspan. He's going to talk to you about appropriate use criteria for radioactive iodine imaging and treatment, dosage, and protocol selection for radioactive iodine imaging and therapy, side effects, risks. Lately, what seems to be a very important topic of controversy, risk of secondary malignancies after I-131 treatment. Dr. Greenspan.
Thank you. It's a privilege and an honor to be here. And you've mentioned the title of my talk, so I'm going to get started. I have no disclosures. These are the objectives: be able to discuss appropriate use criteria, be able to discuss side effects, be able to discuss potential risk or lack thereof of thyroid cancer from diagnostic I-131 administration, and be able to discuss risk of second primary malignancies from I-131 therapy of thyroid cancer. So regarding appropriate use criteria, the following scenarios are appropriate, and that's a category, which means that it's appropriate to use these for evaluation of differentiated thyroid cancer. Initial staging for malignant iodine avid thyroid tissue after thyroidectomy, assessing and quantifying residual iodine avid remnant tissue, post-therapy I-131 localization performed 2 to 10 days after radioiodine therapy, and in my opinion, 3 to 5 and/or 5 to 7 days are optimal. Follow-up diagnostic and restaging evaluation scan, follow-up diagnostic and restaging evaluation scan to determine if the structural lesion is iodine avid. And the following may be appropriate in the intermediate category: follow-up diagnostic restaging scan with prior negative results of I-131 post-therapy images. And as you've heard from the previous lectures, there are a number of features that may mean that that's not accurate. So the diagnostic scan prior to I-131 therapy is listed generally in the guidelines as 1 to 5 millicuries. 1 to 2 millicuries of I-131 is best to avoid the rare complication of stunning. Stunning is rare but real. The post-therapy scan, which is using the therapeutic administration for the scan, and therefore no additional administered activity is necessary. And this is critically important for evaluation of disease status and determination of follow-up treatment, especially administered activity of I-131. And just to be sure everyone's aware, pregnancy and lactation are absolute contraindications to I-131 therapy. Now, in the post-diagnosis and post-surgery setting, which is the first time we're going to be evaluating the patient after surgery, treatment post-op is classified as follows. And these are definitions of the American Thyroid Association. It makes sense to me that since we're collaborating with endocrinologists very closely on these patients, we should use the terminology they're used to so that we understand what they're talking about, understand what we're talking about, and the communication is facilitated. So there's remnant ablation. That's an elimination of normal thyroid tissue. The purpose is to facilitate follow-up by improving subsequent detection of residual or recurrent disease. Adjuvant treatment to radiate suspected but unproven sites of malignancy. Purpose is to reduce risk of recurrence and prolonged survival. And by the way, there's actually a lot of crossover between remnant ablation and adjuvant treatment. Don't worry about that. And treatment of known disease, which is persistent or recurrent disease and local, regional, and metastatic disease. A diagnostic scan, including with SPECT-CT, may be helpful. The post-therapy scan is essential and critical to assess presence and severity of metastatic disease and for providing a basis for subsequent I-131 therapy. Now, I've mentioned, someone else has mentioned low risk, intermediate risk, and high risk. I've listed these again. Low risk is intrathyroidal, differentiated thyroid cancer, less than 5 lymph nodes are involved, and they're smaller than 0.2 centimeters. Intermediate risk, aggressive histology, minor extrathyroidal extension, could have some vascular invasion, and more than 5 lymph nodes are involved, and they could be up to 3 centimeters in size. And high risk, gross extrathyroidal extension, incomplete tumor resection, distant metastases, or lymph nodes greater than 3 centimeters in size. Accurate staging and risk assessment post-surgery are essential for optimizing patient management. So one possible strategy for radioactive iodine therapy is the following. This is the empiric approach with I-131. The activities listed below are one set of recommendations. There are a number of others. but this is somewhat of a consensus, minimal consensus maybe. Remnant ablation, 30 to 50 millicuries, or 1.11 to 1.85 gigabecquerels. Adjuvant treatment, 50 to 100 millicuries, 1.85 to 3.7 gigabecquerels. Small volume local regional disease, 100 to 150 millicuries, 3.7 to 5.55 gigabecquerels. Advanced local regional disease or small volume distant metastases, 150 to 200 millicuries, or 5.55 to 7.4 gigabecquerels. And treatment of extensive distant metastatic disease greater than 200 millicuries, greater than 7.4 gigabecquerels, to maximum tolerated safe I-131 activity. And that's usually measured as that the bone marrow gets no more than 200 rad exposure. So treatment objectives could be cure, progression-free survival, or palliation. We should also evaluate time interval since the previous I-131 treatment, amount of I-131 administered for the most recent treatment, response to the most recent treatment, total cumulative therapeutic activity of I-131, frequency and severity of side effects from previous I-131 treatments. We need to take into account patient wishes and concerns, as mentioned earlier, capabilities of the treating facility, and regulations. Now, as we all know, there are solid, clear evidence of I-131 therapy, and this has been documented by numerous. What? Anyway, there's a clear evidence of benefit from I-131 therapy by a number of investigators, and I-131 therapy is clearly superior to external beam radiation. Now, as far as side effects, they may be uncomfortable, they're rarely lethal, they're usually minimal and transient. And acute side effects include neck tenderness and swelling, painful stomatitis and glossitis, sialadenitis, and some protective measures include hydration and lemon candies or lemon juice, xerostomia, dysgeusia, reduced salivary gland function, which is usually self-limited, and mild temporary bone marrow suppression. Acute or intermediate side effects are the following: radiation gastritis and enteritis, radiation thyroiditis, which you will only see with inadequate total thyroidectomy, xerostomia, dysgeusia, reduced salivary gland function, mild temporary bone marrow suppression, and transient infertility. Potential chronic side effects include permanent sterility, again, potential, chronic xerostomia and painful sialadenitis with sialolithiasis, epiphora, which is excessive tear production, and this can be due to irritation or nasolacrimal duct obstruction, radiation-induced pulmonary fibrosis, and bone marrow suppression, particularly in pediatric patients. So what's the risk of malignancy after diagnostic I-131 therapy? In other words, treating hyperthyroidism. There was a large Swedish study, 24,000 plus patients, had I-131 scans for reasons other than tumor, no history of external radiation. Average absorbed dose was 0.94 gray or 94 rem. The number of observed thyroid cancers was similar to expected. And in patients with suspicion of thyroid tumor, the incidence of thyroid cancer was higher, but that's expected. So in patients with a history of external radiation exposure, risk of thyroid cancer was higher, but I-131 therapy did not increase that risk. In female patients with palpable thyroid nodules, 1,000 patients were examined with I-131 compared to 248 non-exposed patients. No excess of thyroid malignancy was found, but there was a relationship between I-131 and prevalence of thyroid nodules. In the study by Hall, et cetera, 34,000 patients who received I-131 for diagnostic purposes were followed for up to 40 years. Mean thyroid dose is estimated at 1.1 gray, or about 100 rem. 67 cancers found, 50 expected. However, the excess cancers were apparently due to suspicion of thyroid tumor, though the conclusion was excess thyroid cancers due to underlying condition and not radiation exposure. Note that this is not a random patient selection. In the study by Holm, 35,000 patients were administered I-131 for diagnostic studies. Administered activity on average was 52 millicuries. Radiation doses about 0.5 gray or 50 rad, about 1 rad per millicurie, which is what we expect from I-131. The risk of thyroid cancer was not associated with administered I-131. Regarding women of reproductive age, no evidence that treatment by I-131 affects the outcome of subsequent pregnancies and offspring. Risk of secondary primary malignancy, again, in thyrotoxicosis. Dobbins found no increase in leukemia with 19,000 patients. And then the classic study by Eugene Sanger from the University of Cincinnati, known as the Cooperative Thyrotoxicosis Therapy Follow-Up Study. No significant increase in leukemia. They looked at patients treated from 1946 to 1964. Sanger's article came out in 1968. And then there was a follow-up article by Elaine Ron from the National Cancer Institute in 1998, looking at patients. Followed up to 1990. No significant increase in leukemia. Mayo Clinic had a study of 1,000 patients treated with I-131 compared to 2,141 patients treated surgically. No increase in malignancy and mortality from I-131 therapy. And 47,000 Swedish patients in a different study. No increase in leukemia. Now, I brought up those other situations because there are two papers out that purport to show some increase in malignancy from diagnostic administration. I think both of these are extremely faulty, so I've labeled them fiction. First paper is by Molinar, published in the Journal of Clinical Oncology in 2017. Their findings supposedly showed radioactive iodine treatment was associated with increased early risk of developing AML and CML. This paper has many flaws. Administered activity was not evaluated. The follow-up time is too short. They use hazard ratios to show a risk that isn't there, and their numbers are wrong. And in looking through their numbers, if you add them up carefully, the number of malignancies with surgery plus radioactive iodine was 366 out of 68,000. Surgery alone was 417 out of 78,000. And you can see the percentages are virtually identical, 0.538% versus 0.53%. That's about as close as you can get. And in adding them up a different way, 416 out of 68,000 is 0.608%. Surgery alone, 486 out of 79,000, 0.615%. Again, they're basically the same. Conclusion, radioactive iodine in well-differentiated thyroid cancer should be limited to patients with high-risk disease. That's the conclusion from Molinar. I think it's not justified. And also, this paper had some other flaws. The same paper was submitted to a second journal, and 27% of the CPT codes used for thyroid cancer were actually for breast, pancreatic, genital, and bladder cancers. So I conclude that their conclusions are wrong and misleading. That's why I've labeled this study fiction, and you should be aware of it. The next paper is by Kitahara et al. Was published on July 1st, 2019, and they published a revision because there was a mistake in the abstract on August 1st, 2019. And they found a modest positive association with risk of death from solid cancer. I believe the findings are completely incorrect. This paper evaluates a subset of the Sanger paper and subsequent Ron paper, treated with patients treated with I-131 from 1946 to 1964, as I said earlier. Both papers found no association of increased cancer, including leukemia. Neither paper was designed to evaluate cancer mortality. However, the Ron paper did find an increased incidence of thyroid cancer in patients treated with anti-thyroid drugs, but not I-131 therapy. There are many flaws in the Kitahara paper, problems with study design and statistical analysis. For one thing, there's no control cohort. Hyperthyroidism is a known risk factor for increased cancer incidence and mortality. However, that was ignored. Conclusions are not consistent with the Sanger or Ron papers that had 22 to 44 years of follow-up. The model for absorbed dose was not validated. Dose response does not justify conclusions. There's also an increased risk of dementia, cardiovascular mortality with hyperthyroidism that was ignored. And there's an increased incidence of pancreatitis with methimazole that was also ignored. So I believe the findings of this paper are completely incorrect. And I wanted people to be aware of that as well. Now, there was a joint statement by the British Society of Endocrinology and the British Thyroid Association in 2020. They found no control group, model was not validated, no adjustment for confounders. And they also said, advised, don't deprive patients of effective therapy, that is I-131. And the American Thyroid Association published a similar commentary that there is no increased risk of thyroid cancer, and I-131 therapy is effective. Now, radiation fibrosis may develop in patients with diffuse lung metastases, and particularly those who have received more than 5.55 gigabecquerels, which is 150 millicuries at short intervals. This is the Rubino paper from 2003. And Bayerwaltis stated that radiation fibrosis in patients with miliary lung metastases does not occur if iodine 131 treatment is kept below 200 millicuries, so that the lung uptake is less than 80 millicuries, because he never saw lung uptake more than 40%. In the study by Yang, 11,832 patients, almost all were papillary thyroid cancer. We looked at all-cause mortality. 5 years for the papillary thyroid cancers, 22.7% without radioactive iodine versus 11% with adjuvant radioactive iodine. 10-year mortality, 25.5% without versus 14% with. Follicular thyroid cancer, 5%. 5-year mortality, 45.5% without radioactive iodine versus 29.2% with adjuvant RAI. 10-year mortality, 51% without radioactive iodine versus 36.8% with adjuvant iodine. Now, they concluded that there was no increase in mortality with radioactive iodine treatment. It turns out actually it's less in every situation listed here. But there is a significant concern of second primary malignancy, and Mazzaferri and Klus in 2001 stated that there is a statistically significant, higher but still small risk of leukemia in patients with cumulative exposure of greater than 37 gigabecquerels, which is 1,000 millicuries. And this is especially true if that there's been exposure to external beam radiotherapy. Bhattacharya and Cheen looked at 29,000 differentiated thyroid cancer patients, papillary and follicular, 18,000 plus treated without radioactive iodine, 10,000 with. As far as secondary primary malignancy, they found 6.7% without radioactive iodine and 4.8% with. Conclusion, use of radioactive iodine does not elevate the risk of second primary malignancy. It actually looked like it reduced it. In the Hall paper here, 834 patients administered I-131 for therapy of thyroid cancer compared to 1,121 by other means. Administered activity average was 4551 megabecquerels, or 120 millicuries. Radiation dose to various organs ranged from 0.1 to 2.1 gray. Risk of thyroid cancer, other solid cancer, leukemia was not associated with I-131 therapy. In the Salka paper, they found a slightly increased risk of second primary malignancies of leukemia, but not solid tumors. But there are a number of limitations to this study. The minimum latent period for solid primary malignancies, they said, is 2 to 3 years. That's really too short for solid tumors. It's only a minimum of 4 to 5 years. It extends much longer, and the numbers don't add up. As far as leukemias, 0.23%. The estimated absolute risk of leukemia is 0.23 to 0.2%, and 0.4% higher in patients treated with radioactive iodine. But there was limited follow-up time, and some patients were lost to follow-up, and they were unable to evaluate cumulative radioactive iodine dose and risk of the second primary malignancy. So while they did supposedly find a slight increase in risk, it's questionable. So Verkugen found that the incidence of second primary malignancies increased in differentiated thyroid cancer in some cases, probably not due to long-term effect of radioactive iodine therapy, but may be due to common etiologic and or genetic factors. And here are two case reports, 2 cases of AML after I-131 therapy, 2 cases of CML. They didn't mention the total number of cases. In my personal experience, I've treated approximately 120 to 150 cases of differentiated thyroid cancer and have seen approximately 200 cases overall. I've seen 1 case of leukemia throughout my entire career. There was an elderly gentleman who received 900 millicuries of I-131. Follow-up studies in Sweden, United Kingdom, Denmark, and Finland show no increase in second primary malignancy, except for the United Kingdom's study, which showed a small increase. And again, there's an increased risk of malignancy from anti-thyroid medications. Now, this is an interesting paper from Korea, CO et al. Increased risk of leukemia after radioiodine therapy in patients with thyroid cancer. This was a nationwide population-based study in Korea. 542,000 person years. Follow-up from January 2008 to December 2013. 211,360 thyroid cancer patients, of which 72, which is 0.3%, developed leukemia during the follow-up. The follow-up is a bit short. It's only 877 days, median, which is about 2.4 years. Higher treatment dosages resulted in higher incidence of leukemia, especially greater than 100 millicuries. However, so their conclusion was, considering the favorable survival of patients with thyroid cancer and the potential harm of radioactive iodine therapy, physicians need to consider pros and cons when using this treatment option. Well, it's generally true, but there's some limitations here. For one, the risk of malignancy with greater than 150 millicurie treatment is less than 101 to 150, which doesn't really make sense. It's really causing an increase. The risk of leukemia was slightly less in patients with low or moderate radioactive iodine than with none at all, and the follow-up is too short. So I'm not sure their conclusions are really justified either. So in conclusion, there's low risk of mild short-term side effects, probably a small risk of producing thyroid nodules, no definite risk of causing subsequent thyroid cancer, no definite risk of subsequent solid malignancy. This is for diagnostic administration, which is generally in the order of 10 to 20 millicuries. As far as radioactive iodine for thyroid cancer, the risk of radiation pulmonary fibrosis is dose-related. Adverse effect of I-131 on mortality is highly unlikely. Small risk of developing leukemia, plus or minus 0.3%, is mainly with higher administered activity. The risk of second primary malignancy for I-131 therapy for hyperthyroidism has not been definitely identified. However, there is an increased risk of malignancy from antithyroid medications. And I want to emphasize that the benefits of I-131 therapy vastly outweigh the risks. This is for both hyperthyroidism and thyroid cancer. The risk of leukemia is probably slightly increased when the activity is greater than 1,000 millicuries, and therefore consider benefits and risks of I-131 burden will exceed 1,000 millicuries, which is 37 gigabecquerels. There was another reference that said 600, but Nazaferi suggested 1,000. In patients treated with I-131 for thyroid cancer, there is a slightly increased risk of salivary gland cancer that has been seen in some studies, or these numbers are really small. Again, the benefits of I-131 therapy vastly outweigh the risks. And no clear evidence of increased risk of other solid cancers is seen in I-131 therapy. Increased incidence of other solid tumors in some studies, but not others, may be due to a common etiologic or genetic mechanism instead of a causal relationship. Also interesting, there is a bidirectional association of breast cancer and differentiated thyroid cancer. Breast cancer is unrelated to the I-131 therapy. But in thyroid cancer patients, they have increased risk of breast cancer, and in breast cancer patients, they have increased risk of thyroid cancer. But again, the benefits of I-131 therapy vastly outweigh the risks. And that concludes my presentation. Thank you very much.